Thank you, Joe. I am really pleased to introduce three great speakers for today. First, Dr. Laura Hagemeyer, who's an assistant professor of pediatrics in our department since 2015, working clinically at the University of Minnesota Masonic Children's Hospital and Maple Grove Hospital. She completed her undergrad degree at Gustavus Adolphus, followed by med school at University of Iowa and residency and chief residency at the University of Minnesota. Dr. Hagemeyer was always interested in newborn care and completed training in lactation, earning her IBCLC certification in 2017, and is a member of the Academy of Breastfeeding Medicine. About that. And is a member of the Academy of Breastfeeding Medicine. Beyond her clinical duties, Dr. Hagemeyer is a newborn medical director of our postpartum NFCC unit at UMN, and her clinical career focus has also been on medical education. Dr. Pam Heggie is the medical director of the Minnesota Milk Bank and is an adjunct clinical assistant professor of pediatrics at U of M. She practices general pediatrics and breastfeeding medicine at Central Pediatrics, went to medical school at Case Western Reserve, and completed her pediatric residency at University of Rochester, New York. She's a fellow of the Academy of Breastfeeding Medicine and currently serves as the Minnesota AAP chapter breastfeeding coordinator for the AAP section on breastfeeding. And finally, Dr. Beth Jarrett is our first year pediatric hospital medicine fellow at U of M. She's a graduate from Carleton College, went on to complete medical school and an MPH at UMN, and then began her pediatric residency training in Ann Arbor, Michigan, finally completing it this past June at University of Minnesota. She has focused interest in breastfeeding medicine and quality improvement. And with that, I'm really pleased to turn it over to the speakers for their topic on integrating breastfeeding medicine into everyday clinical pediatric care.
Thank you, Dr. Marmette, for that introduction. We're really excited to be here today and hopefully encourage all of you to examine how your knowledge about breastfeeding medicine can affect your patients and their families on an everyday basis. We have no financial disclosures. However, we have breastfed a total of 109 months and counting between the three of us, and expect that this will inform our presentation a little bit today. Here are our objectives. After a brief review of some of the benefits of breastfeeding and the current breastfeeding rates, we're going to use a series of cases to demonstrate how breastfeeding medicine can be impactful for many, if not all of you who are listening today. We will finish with some information on pasteurized donor milk and some local resources, such as the Minnesota Milk Bank for obtaining donor milk for some of your patients. We do want to take one moment as we're getting started to recognize that it is not only moms that breastfeed. During this presentation, you may hear us saying mom or breastfeeding primarily, as this is what is currently reflected in our literature, but this does not negate the recognition for or support of the diversity and complexity of the human experience of infant feeding. So we want to acknowledge the Academy of Breastfeeding Medicine, who has a policy statement on gender inclusive language in regards to infant feeding, and suggest the use of terms like lactating parent, lactating person, chest feeding or body feeding in place of breastfeeding, human milk or milk in place of breast milk to be more inclusive of a variety of different experiences. Please use or replace the term that's most inclusive of your own experience during this presentation, and consider these ideas when you're discussing the topics with your patients. With that, I am going to turn it over to Dr. Heggie to give us a brief introduction into some of the current breastfeeding rates and benefits.
Morning. We thought we would start out today talking about the importance of breastfeeding. And we know that most of you know that already, and so this will be a quick review to put it in the context of everyday pediatrics. So why breastfeeding? It improves health outcomes for babies and children and lactating parents. It saves money both for families and the healthcare system, and it helps the planet. It has an impact on climate change. Next slide. Breastfeeding is associated with less infection, obesity, and allergy in babies and children, and there's a lower risk of SIDS, neck, and overall, there's a reduction in infant mortality with breastfeeding. Breastfeeding also has an impact on lactating parents. There's a lower risk of breast and ovarian cancer, less obesity, diabetes, and heart disease, even 50 years after breastfeeding has been completed. And there's a faster weight loss postpartum, which can have an impact on future type 2 diabetes. And breastfeeding is good for families and the community. Moms have less time off of work due to sick kids. It's a green type of feeding. It creates less pollution and a lower carbon footprint. And it saves money for families in the healthcare system. If more people breastfed, then health outcomes are better, and that leads to saving healthcare dollars. Next slide. Given these health outcomes, the American Academy of Pediatrics says that breastfeeding is a public health issue, not just a lifestyle choice. So in the AAP section on breastfeeding policy statement, the summary is that the AAP recommends exclusive breastfeeding for about 6 months, continuing for at least 1 year or longer as desired by mom and baby. Next slide. So given this is what the AAP says is best practice, how are we doing with breastfeeding rates? So this slide shows a graph of breastfeeding rates in the United States in 2018 from the CDC breastfeeding report card. It's clear that the message that breastfeeding is important has gotten through. As you can see, many women and birth parents begin breastfeeding, but it drops quite quickly over the first 6 to 12 months. Our overall nationwide initiation rate is about 85% for any breastfeeding, which is the blue line, and 65% for exclusive breastfeeding, which is the orange line. So we start out pretty well, but we fall short of the AAP recommendation of 6 months of exclusive breastfeeding, with only 25% of babies exclusively breastfed by 6 months. And only about a third of all babies are still breastfeeding by a year of age, again, which falls short of the AAP best practice. Next slide. So what about in Minnesota? This graph shows that the rate of breastfeeding has steadily increased over the years since 2001, which is great. But there's still ongoing ethnic and racial disparity in the breastfeeding rates in our state. So we have a ways to go to achieve the AAP breastfeeding best practice for all families in Minnesota. Next slide. So now for a bit of breastfeeding medicine history in our own backyard, going back 100 years to about 1912, just before the influenza pandemic. This is a photo of Dr. Julius Sedgwick, who was the first chair of the Department of Pediatrics at the University of Minnesota. He was also a huge breastfeeding advocate, and he studied the effects of breastfeeding on infant mortality in Minneapolis. At that time, the infant mortality rate was about 80 per 1,000 births. And now, just to put it in context, it's 5 per 1,000 births, depending on the population. Next slide. So in 1912, Dr. Sedgwick started a program with home visits by nurses trained in breastfeeding support. It was similar to our current postpartum visits. And the goal of the program was to reduce infant mortality by increasing breastfeeding rates. And what he found was that there was a 20% decrease in infant mortality by 1919. Next slide. So here's the actual journal. This is from the front page of the original article that was published in the American Journal of Public Health in 1920. Dr. Sedgwick reported that the breastfeeding program was associated with a reduction in infant mortality from 81 to 65 per 1,000 live births during the study period. Next slide. And here's another excerpt from the original article. And I'm going to read a few sentences from the article since the content is very relevant for the cases we're going to present later in our talk. So Dr. Sedgwick said that the purpose of the program was to reach the mother of every newborn baby in Minneapolis. And after the confidence of the mother was secured, to educate her first in the value of breastfeeding and second, in the means whereby it could be continued. These methods were very simple. They consisted almost entirely in making continuous demands at regular intervals on the breast and in impressing upon the mothers the importance of properly emptying the breasts. And then further down, the failure to use the mammary gland regularly and completely is the most common and most potent cause for its failure to function. Next slide. And so now fast forward 100 years later to the present day. This is an article that just came out in The Lancet in January 2022. And it's a similar study 100 years later, looking at the impact of breastfeeding on infant mortality. And this was a cohort analysis looking at the impact of breastfeeding on infant deaths in the first year. Next slide. They used US birth certificate data and linked births and deaths to look at the association between breastfeeding and infant mortality starting after 7 days of age. So they excluded early neonatal deaths. And they looked at the association between breastfeeding and infant death in these birth certificate, in this birth certificate data set. And the results showed something similar to 100 years ago, that there was a 26% reduction in all infant deaths associated with breastfeeding initiation. And there was a 40% infant mortality reduction in the first month. So it's most impactful in the first month. And the most significant causes of death that were reduced with breastfeeding were SIDS, neck, and infection. Next slide.
So while the topic of breastfeeding in general is fundamental to pediatrics and something that is likely familiar to many of you, rigorous academia in the field of breastfeeding medicine is relatively new. So breastfeeding medicine is an area of medicine that exists at the crossroads of multiple different subspecialties. Some people like to compare this to sleep medicine, which is another board certified fellowship where people can come in from many different arenas. Think about people coming from internal medicine, family medicine, pulmonology, anesthesia, lots of different places to get into sleep medicine. Similarly, people entering the breastfeeding medicine subspecialty can come from different arenas as well. We most commonly think of pediatrics, family practice, OB as places directly involved with breastfeeding medicine, but this can be a lot broader of a subspecialty when we think broadly about the dyad that we're taking care of. Disciplines like psychiatry, surgery, neonatology, dermatology, anesthesia, just to name a few, encompass the intersection of lactation science and clinical care for the breastfeeding dyad. Since this is a relatively new area and focus within medicine, opportunities are growing daily and monthly. There's a lot of opportunities that we hope to discuss throughout the course of our presentation and with some additional resources at the end for additional CME education and advocacy within the breastfeeding medicine community. The Academy of Breastfeeding Medicine was founded in 1993 and is a worldwide organization of medical doctors who are dedicated to the promotion, protection, and support of breastfeeding. So while there are many other layperson organizations throughout the world, the Academy of Breastfeeding Medicine is specifically physicians who are interested in promoting breastfeeding. This is the most widely recognized source of evidence-based lactation care guidelines. And the Academy of Breastfeeding Medicine has clinical protocols that are widely available. They are published on the Academy of Breastfeeding Medicine website. There are currently 35 clinical protocols across different disciplines and different topic areas, such as hyperbilirubinemia, hypoglycemia, creating a breastfeeding friendly office, treatment of mastitis, really across many different areas of clinical care. These are published in multiple languages and, like I said, relatively easily accessible on the Academy of Breastfeeding Medicine website, evidence-based and well-sourced. The Breastfeeding Medicine Journal, which you can see on the right side of the screen, was first published in 2006 and is currently a monthly journal containing evidence-based peer-reviewed lactation and breastfeeding studies and information. There's an annual international meeting that is relatively well attended by providers and other people interested in breastfeeding medicine. If you are interested, the next meeting is in September of 2022 with both virtual and in-person options available, currently planned to be taking place in Baltimore, Maryland. There's a leadership academy, there's a fellowship of breastfeeding medicine, which Dr. Heggie has completed, which is a longitudinal review and course in different breastfeeding medicine topics. And there's a question about board certification to come in the future, similar to like we talked about sleep medicine or other subspecialty areas of medicine. However, you don't need to be a breastfeeding medicine expert to make a difference for our patients and their lactating parents within our field. So we are going to go through a set of cases to help demonstrate some of the ways that you can make a difference. And while many of these are specific, maybe not specific, but most relevant to the general pediatric or pediatric hospital medicine crowd, I think most of you can find a way to make these patients applicable to you. So I'm going to pass it over to Dr. Jarrett to go through our first case.
Thank you. So our first case is a very common one, a 3-month-old who's hospitalized with bronchiolitis. This patient is exclusively direct breastfed and mom hasn't pumped or introduced any bottles to him yet. Since becoming sick 3 days ago, he's not feeding as well as baseline, but has continued to breastfeed so far during this admission. So you take a look at his weight chart and you see that he's gaining weight well in his growth. He appears well hydrated on exam, but he has had decreased wet diapers from about 6 to 8 at his baseline, but only about 4 per day for the past few days. He's currently requiring high flow nasal cannula for respiratory support at 6 liters per minute, and he's been stable on that level of respiratory support. So to come up with a feeding plan for him. What we want to discuss and highlight with this case is how to best support not only the breastfed baby during the admission, but also the lactating parent. Together, we call them a breastfeeding dyad. The Academy of Breastfeeding Medicine has a protocol outlining what support should be provided to breastfeeding dyads during hospitalization, as you can see here, protocol number 35. The Academy of Breastfeeding Medicine protocol emphasizes that hospitalization of a breastfeeding child can result in disruption of breastfeeding or unattended weaning. In a study of breastfeeding dyads admitted for bronchiolitis, they found that for over 50% of dyads, the hospitalization led to a change in their breastfeeding relationship. So they either stopped breastfeeding altogether or decreased the amount they were able to breastfeed their child. The most common reasons cited for breastfeeding disturbance were a lack of support in the hospital, the severity of the child's respiratory illness, or logistical difficulties in the hospital. So while we might not be able to change the severity of the child's illness, we can provide better support and help navigate logistical difficulties while creating evidence-based feeding plans. The most overarching tenet of this protocol is that all efforts should be made to allow the child to breastfeed on demand. However, feeding on demand may not be enough to maintain a full milk supply if the child's not feeding at their baseline. This is because once lactation is established shortly after birth, it's really based on supply and demand. So milk removal, either by pumping or direct feeding, will stimulate more milk production. On the other hand, a full breast or less milk removal will downregulate milk production. So we know our patient in this case is not feeding as well as baseline. They're breastfeeding enough to stay hydrated, but they're taking in less volume. This is likely downregulating the mother's breast milk supply, and that might not be able to be fully recovered when the illness has resolved if we don't take further intervention. So a comprehensive feeding plan means helping the lactating parent mimic the baby's feeding plan prior to the illness to prevent a decrease in milk supply. So in order to create this feeding plan, we need to obtain a little bit more of a specific feeding history. We find out our patient's currently feeding about 6 times per day instead of his usual 8, and many of his breastfeedings are shorter or less effective than usual. Therefore, our feeding plan would include recommending the mother pump a minimum of twice per day to mimic the previous 8 feeds per day. Additionally, so the feeds that the baby's leaving the breastfeeding full, not feeding for very long, or not feeding very effectively, the mother should try to pump afterwards to mimic a full feed. So we're trying to mimic the full demand to keep the full supply. Our care plan should also acknowledge that this parent is likely very stressed. They might be sick themselves. And we need to ensure that they know that their worth is not equated with the volume that they're pumping. So pumping during this time is more about continuing breast stimulation, and it's not about the milliliters they're pumping. This mother's also never used an electric breast pump. So our counseling and care plan needs to not only make sure she gets a hospital grade pump at the bedside in a timely fashion, but we also need to show her how to use it, how to wash the pump parts, how to safely store breast milk. The CDC has printable handouts on safe storage, including pump part washing and sanitizing guidelines. And the Academy of Breastfeeding Medicine also has a protocol on human milk storage with some interesting details, including the effects of refrigeration and freezing on breast milk composition. I also want to take a pause to say that if you routinely admit breastfeeding diets to the hospital and you don't know how to instruct a parent on how to use a breast pump, please take the time to learn how. Look up a video online, ask a colleague to show you. It's a really important tool to use with our families. Arguably, the most important part of this feeding plan is allowing the patient to continue to breastfeed on demand while on respiratory support. Multiple studies have shown that feeding on high flow nasal cannula is well tolerated and safe. Here we highlight two studies, one from Hospital Pediatrics in 2017 and one from the Journal of Hospital Medicine in 2019. Feeding related adverse events on high flow seem to be rare regardless of the feeding method, and direct feeding might actually be preferable. Infants can generally better regulate the flow of milk with directly feeding at the breast in comparison to a bottle, and the act of breastfeeding can be very calming for an infant. With our goal of minimizing breastfeeding disruption, feeding on a high flow was also shown to shorten the time to discharge in the 2019 study. So in summary, we need to create feeding plans that prioritize the need of both the breastfeeding infant and the lactating parent, with the goal of minimizing disruption of breastfeeding during hospitalizations. We should always prioritize direct feeding when we can, but keep in mind that direct breastfeeding alone may not be enough to maintain a full milk supply when the breastfeeding patient is sick. And oral feeding, including direct breastfeeding while on high flow nasal cannula for bronchiolitis, is well tolerated and safe.
So you might say that was an easy one. I think most of us would ask a parent of a 3-month-old about their feeding type and expect breastfeeding as a possible answer. But with our next case, I'm going to ask you to challenge some of your biases that you may not know you have around breastfeeding. So case 2, we have a 2.5-year-old previously healthy female who is admitted with viral gastroenteritis and dehydration. She has been refusing all PO by cup, bottle, or spoon. She initially had some decreased urine output, but now is voiding since admission to the hospital. She received a normal saline bolus in the emergency department and has received about 6 hours of maintenance IV fluids, is no longer vomiting, but just lost her IV. Mom is with her and requests that she try to nurse her before she gets a new IV, as she was a hard stick on initial IV placement. So what's your initial response? Many of us may have even forgotten to ask or not even known to ask if breastfeeding was ongoing for this dyad. And even if we did know that she was breastfeeding, we might have thought, how much milk could this parent be making? If they've been breastfeeding for 2.5 years and this kid is eating food, are they actually making any milk? Is breastfeeding for the mom? We hear a lot of these different kinds of responses when we think about toddlers and older children breastfeeding. There's a lot of bias and a lot of lack of understanding about older children and older breastfeeding dyads. It's impossible for us to know how much hydration this child could receive from breastfeeding unless you ask. There's a Peds in Review article on acute gastroenteritis from 2012 that suggests continued breastfeeding both during the rehydration and maintenance phase of treatment. So if we're using evidence-based medicine, we're going to let this family breastfeed. The question is, how much hydration is this actually going to provide for our patient? There are probably more toddlers and older children breastfeeding than we know about. And if we were sitting in WILF right now, I would ask those of you in front of me to raise your hand if you or someone that you know has breastfed past 12 months of age. But instead, I'm going to have you look at this really tiny and somewhat outdated graph that shows us that from CDC scorecard data that Dr. Heggie was presenting earlier, although older, probably at least 10% of patients are breastfeeding at 18 months of age in the United States. Recent pandemic data suggests that this number may be increasing due to a variety of causes. One of those being parents being more accessible, not needing to pump as much at home because they're working from home and they have their infants more easily accessible, and also the hope for increased immune support and possible antibody transfer after vaccines in the age of our current pandemic. The duration of optimal breastfeeding is really variable. And the Journal of Pediatrics Optimal Duration of Breastfeeding report in 2020 provided evidence that exclusive breastfeeding for the first 6 months of life with continuation of breastfeeding after the introduction of solids promoted optimal health and well-being for the mother and the infant. This paper notably left out an end time for the duration of these benefits. So really didn't say, when does it stop? Breast milk doesn't turn into water. It doesn't become nutritionally void at 12 months and 1 day of age. So there's really, a lot of good information out there that continued breastfeeding may be important and a more common occurrence than we know. The WHO recommends exclusive breastfeeding for the first 6 months of life with continued breastfeeding up to 2 years and beyond. As we heard earlier, the AAP says exclusive breastfeeding for the first 6 months of life with continued breastfeeding for 1 year or longer is mutually desired by the mother and the infant. Worldwide, UNICEF reports that half of children are breastfeeding at and past the age of 2. And the natural age of weaning is likely a lot older than we give credit for. So if you look at anthropologic data, data from traditional societies, and previous reports, the natural age of weaning is likely closer to 2.5 to 3.5 years of age. This is a lot of words to say this decision and judgment isn't ours to make. So while we know and I recognize that breast milk is not going to be the sole source of nutrition for a child after 1 year of age, there are many benefits to breastfeeding beyond calories, and we need to leave that decision in the hands of our dyad and not on our own society or our own biases. So all of this is to say the 2-year-old in our case or on your service may very well be breastfeeding. It's not all that unusual, and you may not know about it, again, unless you ask. So back to our case. We find out on social history that there is a 2-month-old sibling at home. This is a same-sex family. One parent births each child, and both parents are breastfeeding the children. This practice is referred to as tandem breastfeeding, or breastfeeding 2 children at the same time that are different ages or are not twins. And while this is not an incredibly common practice in the United States, it does occur. The data around this topic is pretty scarce and primarily subjective, but some nutritional data from European studies does show that if the younger nursling is prioritized in the feeding plan, the lactating parent can provide adequate nutrition to the young child, as well as the benefits of breastfeeding to the older child. For our case, the lactating parent is going to be able to provide you the best estimate on milk supply and the amount of hydration that she will be able to provide for this child. Their milk supply may be more robust than the person who is occasionally feeding their 2-year-old, before bedtime on occasion, because there is an infant sibling at home. But again, we're not going to know unless we ask. This parent reports that she's been pumping 3 to 4 ounces every 3 hours while this child has been sick and not breastfeeding. The child has good milk transfer at the breast when healthy. And all of this data says maybe we do have a reasonable option for oral rehydration here. So lastly, if this family discloses tandem breastfeeding to you, or any family discloses tandem breastfeeding to you, congratulate them. Your support will empower them and be probably unexpected, as it's not a common response from the healthcare society. And it may improve your relationship with this family and allow you to make more accurate and improved shared decision-making for this patient. So similar to the last case, if the child was not feeding well, we want to encourage you to use the prior principles to help the parent support their milk supply. Make sure the lactating parent has supplies, has a pump, knows how to use them, has a place to store the milk and wash pump parts. But for our patient who is willing to feed and interested in breastfeeding, we need to consider being inclusive of alternative ways to determine hydration. While I wish we would have evolved ounce markers on our breast, that has not happened yet. And it is impossible to say, oh, my baby ate 2 ounces. So if you're going in the room and saying, how do they feed? How much have they taken? and the mom or the parent looks at you and says, I don't know, they nursed 3 times, that's a reasonable response that doesn't necessarily need those milliliters or those ounce objective data. We can use things like clinical exam, vital signs, eyes and nose in a non-critically ill patient to determine hydration and to determine if breastfeeding is adequately supporting this baby's or child's nutritional needs, or not nutritional needs, hydration needs. So in summary, don't let your own biases and norms limit your options around hydration and feeding for children over 12 months of age, as breastfeeding may be a reasonable alternative or option. You won't know the extent or quantity of breast milk available unless you ask the questions. Tandem breastfeeding is possible and nutritionally adequate for all involved if appropriately managed. And I'm asking you to consider the use of subjective measures of hydration when breastfeeding patients are not critically ill. You will help support that breastfeeding dyad both in the hospital and their goals going forward. So now that we've talked about older kids and breastfeeding, how about ones with complex medical needs?
So our third case is a 2-month-old with AV canal. They're exclusively direct breastfeeding, but they're not gaining weight and approaching surgery. So need to come up with a feeding plan, a new feeding plan. Previous attempts at supplementing with bottles have not been successful as the infant refuses to bottle feed. The mother would love to continue direct breastfeeding and provide exclusive breast milk both before and after surgery. So our goal is to come up with a feeding plan that will help meet this patient's growth requirements, but also meet the dyad's breastfeeding goals. I think it's important to really get down to the nitty-gritty details of this family's breastfeeding goals. Is it providing as much breast milk as possible, direct breastfeeding as much as possible, minimizing pumping? All of these specifics will really help you direct your feeding plan. So we know that breastfeeding has important health benefits for infants and mothers. However, because of evidence of improved outcomes with a breast milk diet in infants with congenital heart disease, I would like to frame breast milk as a medical intervention for these patients. So infants with congenital heart disease who are fed breast milk have improved weight gain in comparison to those who are fed formula. This can even include infants who have surgical complications such as a chylothorax and have to receive skimmed breast milk. We often think of a decreased risk of NEC with preterm infants in a human milk diet, but we also see a decreased risk in infants with congenital heart disease. And I think it's important to say that direct breastfeeding is safe in infants with congenital heart disease. In fact, they found that infants can have better oxygenation, more heart rate and temperature stability when they're direct breastfeeding in comparison to bottle feeding. Breastfeeding success in this population directly correlates with maternal breastfeeding education, which again highlights the importance of our support for these dyads. So again, the task in this case is to create a feeding plan to improve weight gain while prioritizing direct breastfeeding. So a great tool or a great plan to start with is something called triple feeds. So triple feeds are a 3-step process. So direct breastfeeding followed by the mom pumping and then utilizing a supplemental feeding. In this case, the babies refuse bottles, and so I would utilize a tube feeding. You can definitely start with an NG tube, but in an infant that's likely going to need long-term supplementation, a G tube is a great resource here. The supplemental tube feeding can then be fortified to provide extra calories. So you can add formula, or in some cases, mothers can be taught to fractionate their milk so that the milk provided in the supplement is higher in fat and calories. You'll want to estimate the volume that the baby's getting at the breast so you can then calculate how much to give in the supplemental tube feeding. And you can do something called a weighted test feeding. So you use a specialized scale, you weigh the baby before direct breastfeeding and after, and the difference in weight is a pretty good estimate of the volume they're getting directly at the breast. So there are definitely advantages to this plan. The dyad can continue direct breastfeeding. It's a way that you can provide a supplemental tube feeding that's exclusively breast milk. You can increase the volume and calories in the supplementation. But there's a major disadvantage. It's very time consuming. You have to pump after almost every feed. So this general outline can be modified to fit different goals or adapted as goals change. Or if mother does not have enough milk supply to provide the supplemental feeding in the tube. You can continue to direct breastfeed and then provide fortified formula through the tube feedings. This can really decrease the pressure on the direct breastfeeding relationship, on the milk supply demands, and you can really focus on the comfort and bonding aspect of breastfeeding. I want to take time to acknowledge that there are multiple ways to provide breast milk and ensure adequate growth, including in our patients with complex medical needs. So for some dyads, direct exclusive breastfeeding works wonderfully. We talked a little bit about triple feeds. So that could be direct breastfeeding and pumping and bottle feeding, or breastfeeding, pumping, and tube feeding. The picture on the far left here is an example of a supplemental nursing system. So with this, the baby's getting some supplemental feeds while also direct breastfeeding at the same time. Exclusive pumping isn't also an option. You can exclusively express or pump breast milk and feed it either with a bottle or by a tube feeding. The picture of the baby in the middle there is my daughter about 4 years ago. We did about 2 months of triple feeds when she wasn't gaining weight, followed by many months of exclusive pumping and bottle feeding. And that's what worked for us. So taking time to sit down with families, including those with complex medical needs, and create a unique feeding plan to meet their breastfeeding goals and their growth requirements is so important. So part of this mother's goal in this case was to breastfeed before and after surgery. Breastfeeding in the postoperative period has been shown to be safe in this population, with actually a decreased need for pain medications and blood control medications. This is likely related to oxytocin release, not just in the lactating parent, but also in the feeding infant. There's definitely a need for a careful fluid balance in the postoperative period, but breastfeeding test weights have been shown to provide a measurement of intake that can help safely manage fluid balance in these patients. So in summary, breastfeeding should be supported in our patients with complex medical needs and really seen as a medical intervention based on evidence of improved outcomes. And there are multiple ways to breastfeed and provide human milk to meet our patients' goals and growth requirements.
All right, so here's our last case. We're running through these relatively quickly. This one is a common clinical scenario for those of you that work in the newborn nursery or see newborn patients in the primary care setting. And it's less focused on the medical details of the case, but we're going to use it to highlight some of the appropriate use of donor milk and some resources, local resources in obtaining that donor milk. So here is a really cute little 3-day-old born at 37 weeks due to preeclampsia, discharging from the newborn nursery. Baby was born by C-section, which was also complicated by postpartum hemorrhage. According to gestational age and just newborns in general, baby has been sleepy, breastfeeding fair with attempts every 2 to 3 hours. They have been supplementing with donor milk in the hospital due to early weight loss for the baby and decreased urine output. The nurse brought a pump into the room and told mom it would be good to pump before, or if she's going to be supplementing the baby. And mom attempts once before discharge without any collected volume. Now baby is presenting to the PCP for a newborn visit. A couple days later, baby's 5 days old. Mom reports long feedings lasting over an hour. She's waking the baby to feed every 3 hours. And looking at her, she's on her last straw. She is exhausted. She's got cracked nipples. She's sore, and really, looks like she's barely hanging on. Weight loss is down 10% from birth weight. Baby has voided twice and had no stools in the past 24 hours. Mom hasn't been pumping due to those long feedings. And they have donor milk at home from the hospital that they've been giving every 3 hours, giving 15 milliliters by syringe, but that supply is dwindling, and she's not really sure what to do next. I want to highlight on this graph here on the right. This is a figure from the newborn early weight loss tool, and if you don't do newborn medicine, you may not have used this before, even if you have. It's basically a reverse growth chart, or shows kind of normal weight loss in the first 30 days of life divided out by type of delivery and also type of feeding, breast milk, exclusive breast milk feeding, formula feeding, or both. And it can be really useful to move away from that strict 10% weight loss is bad mentality that many of us learned, and to really help us look at the clinical scenario. So in this, what you see, I graphed a baby who would fit this case here. At 5 days of age, that's that last data point to the right, you have a baby who is 10% down from birth weight, and really isn't in that what I would consider a danger zone. So the dark red color is the 95th percentile. So 95% of babies haven't lost that much weight at day 5. So that baby really isn't in that danger zone. But what I want you to think about here is the clinical scenario. The number plus the clinical scenario is what I'm concerned about. This baby isn't peeing well, isn't pooping. Family is kind of at their wits' end, and we need to come up with something for this baby. So what do we do? What does this baby need? The baby needs more milk. And supplementing, the word supplementing can get a bad rap in the breastfeeding world, but no one is denying that this baby needs to eat more. The Academy of Breastfeeding Medicine has a clinical protocol on discussing supplemental feedings in healthy term infants. Goes through some great clinical scenarios to help you determine when supplementation is necessary. And for this patient, again, based on that lack of weight gain, inadequate output, extended duration of feeds, and some maternal risk factors that increase the risk for delayed lactogenesis 2, early term delivery, C-section, postpartum hemorrhage, this baby needs supplementation. That 15 mils every 3 hours, well, that may have been an appropriate supplementation volume when leaving the hospital, quickly became inadequate for this patient, and he's no longer getting enough. The pitfall in this case is giving that donor milk without the education and lactation support to improve mom's supply and work towards those adequate breast milk volumes. So the supplementing cycle that you see in this graphic here is a physiological and psychological phenomenon. The more we supplement a baby without adequately supporting mom, both physically and psychologically, the more we undermine her confidence and her milk supply. So we need to get baby more food, get mom pumping so that she's able to make more food, and find a way to do this while maintaining her sanity. So if we're using donor milk in the hospital, there's a way that we can do it to improve and promote the breastfeeding goals of the lactating parent. When families discharge using donor milk or formula as a supplement, the parent should be given instructions on increasing volumes after discharge to make sure that the baby is, following clinical signs that the baby is getting enough to eat. I will often say, if you're giving baby milk that you didn't make, you need to tell your body with pumping or hand expression to put in a bigger order for next time. So really what we're doing is supporting the parent to improve their milk supply, to use that donor milk or formula as a bridge while that mom's milk supply is increasing. Donor milk that's given without education or lactation support compromises future milk supply and the success of the family's breastfeeding goals.
So we want to emphasize that when we say donor milk, we're talking about pasteurized donor milk from a milk bank and not peer sharing. This donor milk is used as a bridge, just like Dr. Hagemeyer talked about earlier in case 4, as moms build their milk supply. And while many studies have shown that mother's own milk leads to the best outcomes, sometimes there can be a delay in lactogenesis, and moms have difficulty making a full milk supply, especially in the NICU, sometimes due to the medical conditions that moms have that may have led to their baby's prematurity or illness in the first place. So donor milk can be used to reduce the risk of NEC and to improve other NICU outcomes, such as ROP, retinopathy of prematurity, and chronic lung disease in the NICU. And while we often think of donor milk in the NICU, it can be used for full-term babies for supplementation, again, as we heard about in case 4. And this banked milk helps to give a positive message to families that breast milk is important. And it also helps moms and lactating parents reach their infant feeding goals. It's less discouraging for families to know that their baby's getting breast milk if supplementation is needed, especially if their goal is exclusive breastfeeding. And also donor milk prevents early sensitization of the gut with cow milk proteins from formula, which can lead to later allergy at times. Next slide. So now we're going to talk about the Minnesota Milk Bank and how it got started and where it is now. Because basically it's a local source of pasteurized donor milk for the Minnesota community. So this slide gives an overview of the milk bank development. And for many years, Minnesota hospitals could only obtain donor milk from milk banks in other states, such as Colorado and Ohio and Iowa. And about 10 years ago, a nonprofit was established called Breast Milk for Babies, with a vision to raise funds to open a milk bank in Minnesota in order to have a local source of safe pasteurized donor milk for our Minnesota hospitals. The funds were raised through donations and grants, and over the 10 years, the funding increased, and the Minnesota Milk Bank opened in November of 2019, just before the COVID pandemic started. It's been accredited by Humana, which is the Human Milk Banking Association of North America, which is the national organization that assures safety of milk banks. And over the last 2 years, the milk bank has grown quickly. It now serves over 25 hospitals throughout Minnesota, including all of the hospitals in the Twin Cities and at the U. And there are 31 depots, which are milk collection sites where families can drop off the donated milk, including here at the Masonic Children's Hospital, where we have a milk depot for the milk bank. And there are multiple distribution sites for the outpatient purchase of donor milk located at pharmacies, birth centers, hospitals, and clinics. Next slide. Next, I'm going to give a quick overview of how the milk bank works, from the donor screening through pasteurization to distribution of the pasteurized milk. First, who can donate? Not everyone who wants to donate can donate their milk to a milk bank. There are strict protocols for donor acceptance. Lactating parents need to be healthy and go through a rigorous screening process, which involves a review of their medical history, travel, medications, supplements, and lifestyle issues to make sure the milk is safe for preemies and medically fragile infants who get most of the donor milk in the NICU. The milk donation is voluntary. Just like blood donation at the Red Cross blood bank, the donors are not paid for their milk. There are 4 steps the donors go through before being approved as a milk donor. First, there's a verbal phone screening, again, going through health history and information about medications and herbs and other things that might be affecting the safety of the milk. And then they have to complete a written application about details of their health history. And there is sign off from their OB and pediatrician or family doc saying that there are no concerns about milk donation for the mom and the baby. There are labs done for HIV, HTLV, hepatitis, and syphilis. And if all is passed, the donor is approved and can donate her milk. And we always like to emphasize that the labs are paid for by the milk bank. So it doesn't cost moms anything other than their time and their passion to go through the process of being screened for being a milk donor. Next slide. And as I mentioned before, the milk bank has 31 depots, which are milk collection sites around the state where moms can drop off their milk in their local community after becoming an approved donor. All the depots have freezers to hold the milk, and then there are milk bank staff or volunteers who make regular pickups and transport the milk to the milk bank. And as I mentioned before, we have a depot here at the University Hospital, and the photo on the left shows a socially distanced milk drop at the Masonic Children's Milk Depot, and that was early in the pandemic, when we didn't know so much about contact. And so this is a contactless milk drop off at the depot. And the other photo shows a freezer in southern Minnesota at the depot in Fairmount. And that's where the milk is stored until the milk bank transport team comes and picks up the milk and takes it to the milk bank. So next slide. So this slide shows some more examples of people dropping off their milk. Dads are often very excited about transporting milk too, as you can see on the far left here. And on the right is a picture of a pilot from Angel Flight. And that's a program where volunteer pilots fly to pick up donated milk at some of our outstate depots, such as in Roseau in northern Minnesota at the Canadian border. And it's similar to what they do for organ transport for organ donation. And so they'll fly up there in different areas and pick up milk and then bring it to the local airport, and then we pick it up and bring it to the milk bank. Next slide. So then the milk gets sorted and thawed at the milk bank, and then it moves to pasteurization. And the goal of pasteurization is to heat the milk enough to get rid of the pathogens, but not so high that it denatures the bioactive components of the breast milk. So the goal is to retain components such as secretory IgA and other proteins. So for safety, the milk is heated to 62.5 degrees Celsius for 30 minutes, which is the Holder pasteurization method that most milk banks use throughout the country. And the effect of pasteurization on the milk is that it destroys the pathogens such as HIV and CMV, but at the same time, it also destroys the cellular components present in the fresh breast milk. But there's still a lot of good stuff left, as you can see in the slide here, that the HMOs are retained, secretory IgA is about 50%, and there are lots of micronutrients that are still present. Next slide. And another exciting aspect of the milk bank is that there's collaboration with the mHealth Fairview Specialty Pharmacy for a donor milk home delivery service. The specialty pharmacy will do home delivery of donor milk for outpatient use after a baby is discharged. And they're happy to add boxes of donor milk to their delivery trucks, since they do lots of home deliveries for medication and supplies for patients getting home care in the mHealth system and also outside of the system as well. And one of the lead pharmacists had a granddaughter who used donor milk. So he was totally on board with this partnership, and it's been really exciting to see this expand in the last year. Next slide. So a little bit about the donor milk distribution site here at mHealth Fairview. As I said, it gives home deliveries, and it's a next day home delivery. So you have to plan ahead if you're discharging a baby to make sure that the milk can be sent out to the home the next day. But parents can come and pick up the milk at the pharmacy or at other distribution sites throughout the Twin Cities. And there's a discharge order set in Epic for the donor milk. And then that gets sent right over to the pharmacy, and then they set up the order for a home delivery the next day. Unfortunately, the families have to cover the cost of outpatient donor milk, and not in the hospital pays for it. And it's expensive because of the processing costs of the milk pasteurization. Some states have insurance coverage for it, but not here in Minnesota, but there's ongoing advocacy to try to get that coverage here. Next slide. And then I'm going to briefly just mention that we have a milk bank bereavement program when milk is donated after a baby has died. Next slide. So this is the program called our Forever Butterflies. Next slide. It includes a handmade quilt that hangs on the wall at the milk bank honoring babies who have died and the milk that was donated by their parent. And the baby's name is embroidered onto a butterfly with their baby's date of birth, and families can visit the milk bank. And there's also a brochure that is available to have families who have lost a baby know what to do with lactation options, such as expressing milk, donating milk, or if families, parents feel that they would rather suppress their milk, with information about how to dry up their milk. And then lastly, some of you may have seen in the paper this past weekend that there was an article about the milk bank bereavement program in the Star Tribune, and here's the headline. And the donor in the photo, Tiffany, said she donated her milk after her baby died because I can sing to him, talk to him, and know that together we're helping other people feed their babies. Next slide. And here's another photo from the article. Donated milk can bring healing. And this baby died soon after this photo, and his mom, Carolyn, donated her breast milk to the milk bank and did ongoing pumping, which was healing for her. Next slide. Just a little bit about bereavement and milk and what helps. And I'd like to just emphasize that thinking about milk donation similar to organ donation, that if, like when a child dies in the hospital, staff may contact LifeSource to help coordinate organ donation and to work with the family. And milk donation can be similar, and reach out to the milk bank, and the milk bank can help talk families through if they're wanting to donate milk. That can be quite healing. Next slide. So in summary, the milk bank is a local source of pasteurized donor milk for inpatient and outpatient use. So if you hear of moms who have extra breast milk that their babies don't need, send them to the milk bank. And then we're just going to go back to Laura for a few more bits of information about breastfeeding medicine.
So here's our summary. We hope that we've given you some information to help you realize how breastfeeding medicine is a part of your practice, whether you're recognizing it or not. Giving you some sources for evidence-based in breastfeeding medicine and lactation care, and some local resources, including the Minnesota Milk Bank. There are a lot of different physician associated resources for breastfeeding that are listed on this slide, but we also want to encourage you to reach out to any one of us at any time if this has piqued your interest, or you have additional questions about breastfeeding medicine or how we can help support those families in our care. And we want to leave with just this beautiful picture of many different ways to breastfeed babies, and are happy to take any questions.
Thank you so much. We're actually at time. That was such an amazing, informative, and practical presentation. I want to invite people to reach out directly to our three panelists if they have questions, and those can be answered offline. Thank you so much. That was terrific.
Thanks, everybody. I put the link in the chat for the continuing education portal, so please go get that MOC2 credit while you're thinking about it. Click there, find today's talk, and click the button that says tests.